tell us about this.
Thank you very much, Hassan. Mr. Chairman, Dr. Fawaz, committee, colleagues, it's a pleasure to be here and do these talks. Hopefully I can sum up in quickly what we need to do. This is what came from Leicester University, and I'm proud to say recently we've exceeded Oxford in terms of publication, and I have a few publications under Leicester University. This is, I believe in this quote, and in every presentation I do show this quote because of the benefit of this one, imagination. I think we all, in our profession, it has a major role in how we approach our patients. And our imagination, as per Einstein, is the one that embraces the entire world, stimulating progress, giving birth into evolution. I think all what we do now is down to this great professor. In 1929, Professor Frostman, he performed his first angiogram on himself. He did it through his anticubical vein, and he believing that every vessel will lead to the heart. Down to this man, we all do what we do now. And I think it takes every century probably one genius person like him to change the world, how we manage, how we approach humanity. I just want to make one comment briefly, Hassam, about the great question that you've asked about what's the future in bicuspid valve. We know it's different etiology, different animal altogether. In my view, we're all thinking surgery is first line. I think the future will line into debulking the valve. The key part is debulking the valve. And we started to see some devices now to debulk the valve. And we've seen one in Euro PCR, and I think it's a very promising device in which you inflate a small device cylinder within the valve, and then a sheet will go rotate around the valve and break the calcium. They've shown some data already in a human showing massive benefits. So I think the enemy of calcium in the bicuspid valve and in all aortic stenosis, I think if we can eliminate that, as we do with the coronaries by rotablation or whatever orbital atherectomy, I think will make massive difference for the future, how we treat our patients, particularly the bicuspid valve. I'll just whet your appetite with this slide from the JACC publication. As this is Marco Barbanti, looked at the prevalence of the coronary artery disease post-TAVI with various valve structure. As you can see, Medtronic, you've got the self-expandable valve, you've got balloon expandable valve, and across the board, I'll show you some data, what the prevalence of coronary artery disease and how important it is. So I'll talk about the prevalence, outcome of coronary artery disease, revasc in the context of aortic stenosis. Indeed, everybody talks in every meeting about coronary access, the new challenges on the horizon. Valve in valve, we're going to deploy this in younger generation. Patients will need more than one TAVI in their lifetime. What are we going to do about coronary access? Self versus balloon expandable TAVR. Where do we stand right now? This publication is really fascinating. They will talk about coronary artery disease and transcatheter aortic valve replacement, state-of-the-art review. And I'll show you the prevalence of coronary artery disease in all patients with aortic stenosis is 50 to 60%. So we all face those patients in our practice, and it's not a small percentage. We always scratch our head as what to do. Shall we address those patients prior to their TAVI procedure, or shall we leave it afterwards? In randomized controlled trials, the prevalence of that was 15 to 30%, and I believe it's down to patient selection. As always in randomized trials, the patient selection will always skew the data. I think the prevalence of coronary artery disease is much more higher than that. Prognostic role of coronary artery disease in patient undergoing TAVI is still debatable. Shall we do it or shall we not? I think there is a way that we can stratify those patients, which one we should approach and start with the revasc prior to their TAVI. The PCI per se, percutaneous approach to those coronary artery disease in advanced aortic stenosis, there are some challenges with that. And we all face complex anatomy, risk of hemodynamic instability, and bleeding complication. You're going to poison them with dual antiplatelet for a quite duration. And the question is that going to be beneficial to our patients? This is Farrox et al. In 2019, he looked at the data from our randomized trial. As you can see, from partner trial, the core valve registries, TAVI, I mean, across the board, you can tell the prevalence of coronary artery disease. And again, it's lower than real-world data. I think it's due to the fact that in randomized control trial, quite often there is patient selection. Here's one of his conclusions, that CTCA is a reasonable alternative to coronary angiography in those patients. Should we do angiography for every patient prior to TAVI? I think we are all doing it right now, but maybe for the future we will do CT coronary as opposed to coronary angiography. There are a number of trials, as you are aware, using the FFR, IFR, prior to aortic stenosis with its limitation. During to the aortic stenosis. I know some people don't believe in FFR data or functional assessment coronary artery disease in the presence of aortic stenosis for the obvious reasons, yet I think there is quite significant, strong data to suggest it's a very valuable method. The impact of coronary artery disease in patients undergoing transfemoral, this publication, I'll show you some of the methods how they did it. So basically, the complexity of the coronary artery disease plays a major role in how we approach our patients. For example, patient with proximal LAD, distal left main, the dominant RCA with osteal disease. Would you approach those or would you not? I mean, certainly we rely on the syntax score in those patients. And this paper did look at the syntax score in those patients prior and after revascularization to look at the outcome in those patients. And I'll show you what they conclude in the paper data. Basically, they said the anatomic severity of coronary artery disease as assessed by the baseline and residual syntax score is associated with survival after TAVI. So we're talking about prognostic benefit if the syntax score is high in those patients. Coronary artery disease seems to reflect general comorbidity, burden, and is associated with a higher risk profile of the patients. I think the hot talk nowadays is coronary access post-TAVI. Is that simple or not? I mean, we need some data to show. We all believe that we can access any coronary anytime after we deploy our valve. Is that real or not? I'll show you some data. This is a JACC publication, and the percentage of unsuccessful cannulation was 7.7% in TAVI re-access study. There was a large study recruited over 1,000 patients, basically looking at how we access our patients' coronaries post-TAVI. And they used different all-modality valves, including Medtronic, Boston, and the new generation. This is what they concluded, and as you can see, unsuccessful cannulation, you see the yellow bar, and in terms of the green bar, that's semi-selective cannulation. You have to fish with your wire to get into the coronary. Imagine this with somebody coming to you with acute ST elevation myocardial infarction, and you start fishing with the wire into left main to open up their LAD. This can be a challenge to all of us. Now, what are the predictors of unsuccessful cannulation in the re-access registry? Actually, it's one of the main predictors, as you can see, was the Evolute transcatheter aortic valve with a p-value less than 0.001. So it's the use of self-expandable valve that definitely is more difficult for us to access the coronary arteries for our patients. Now, in that regard, as we all know, the registry, the data on self-expandable valve versus balloon expandable valve, the durability and longevity is in favor of the self-expandable valve. And the recommendation now more to use self-expandable valve. So we have to take that into account. And I think the industry, they have to work hard in order to design a better stent form for us to allow us to access the coronary arteries Particularly, again, I emphasize on this, we're going to be using TAVI in very young generation who will require more than one TAVI during lifespan, and hence there is more emphasis on the stent frame as part of the success that we look at a long-term outcome for our patients. So this is the Evolute transcatheter valve was a predictor. Transcatheter aortic valve implant death, as my previous speaker rightly documented, that we need to pay a little bit more attention how we deploy the valve. It's something, a factor that is essential and a predictor of how we can access our coronary artery disease. Now, the ED ratio, probably Dr. Abdul will talk better than me about this one, the ratio between transcatheter aortic valve and sinuses of Valsalva. That's why I say always the data from the CT are crucial for us. When you study the CT and prepare to your procedure, you really make a huge difference to the long term of your patients. We've been through this and we've seen how we access those valves, and as you can see, the shape of the catheter that are widely used. Surprisingly, the majority of those Jetkins catheters, they can access your coronary arteries. And I think during last year, live case from Saudi, Jeddah case, the operators, I think they've shown us very, and I love that approach. After every TAVI, they access the coronaries. They show which catheter they invest for about 4 or 5 minutes, accessing the coronary arteries, the left main and the right coronary artery. And that investment will pay big-time dividends in the long term for those patients. So if you document in your report, I've accessed the coronary, the left main, by an ABU 3.5 catheter, wherever the patient will go in the world, he will have access to his coronaries by this catheter. It will save a lot of valuable time. This is a JACC publication. Again, it was in 2019, April, talking about aortic valve and coronary artery disease in the TAVR age. I like the definition that came up by Francesco Polari. He said, the two brothers with independent destinies. I mean, you can take from that statement whatever you want, but I think it's something, it means that we should pay more attention to this with the emerging data, that it is a predictor of long-term outcome in our patients, that we fix the high syntax score in coronary artery disease. In this paper, it was talking about what's the incidence of acute coronary syndrome following TAVI procedure. I mean, I think this is an important paper addressing this factor that we all like to know. What is the percentage of our patient following TAVI, they present with acute coronary syndrome, where in that time we need to save very valuable time. This is the number of patients who were recruited in this study, 779 TAVR patients. 78 of those had an acute coronary syndrome, and 701 they didn't have any events. This is, we're talking about 50% of them, the 50 patient, or 64% had NSTEMI, 1 patient had STEMI, and 27 patients had unstable angina. What's the outcome of those patients? This is the Kaplan-Meier curves for ACS post-TAVI. And as you can see, it's a very high-risk event if it occurs to our patient post-TAVI. And this is, we're talking about 30-month follow-up for those patients. The MACE event, if you have an acute coronary syndrome event following TAVI, it's nearly 50%. So 1 in 2 of your patient will have a major adverse cardiovascular events if they present with acute coronary syndrome. In terms of death, hard facts, we talk about over 40% there is mortality associated with presenting with acute coronary syndrome. In terms of myocardial infarction, around close to 20%, and indeed, with new revascularization, we talk about 15%. So any event, acute coronary syndrome, post-TAVI, is a serious, serious matter for our patients. And I think we should consider that in future trials, indeed studies, to look at how we address our patients with significant CAD. And now, I think the future will lie in terms of younger patients. Again, we have to be very careful about this issue.
I think...
time?
Yeah, time.
I'm sorry, did I take...
No, actually, it was a fantastic journey that you took us through the...